All right, guys. So I wanted to come on this afternoon. Well, it's afternoon for me, but it might not necessarily be afternoon for whenever you're watching this. But I wanted to do just kind of a bonus module in regards to genetics and then common blood disorders that are related to genetics. More specifically, we're going to talk about hemophilia and von Willebrand's disease. And so, just like any other kind of episode that I've recorded for you guys, I think we need to start with a background. So, always and forever, I'm going to get a starting off place for you guys, just so we're on the same page. Because again, I don't know kind of your history and what you've learned in the past, or maybe what you haven't learned, or maybe sometimes you just need to hear it a different way. And so let's talk about a couple of different definitions that we have here today. So we have genetics that just talks about hereditary, and the variations of how these traits get passed along to our offspring. Or the opposite end of that would be maybe what got transferred to us or inherited to us as the offspring of our parents, and what we can potentially pass along to our children. Genomics is a general term for the function of all human DNA. There's been a lot of genomic testing, a lot of genomic research in actually helping some of these genetic disorders and learning where they come from and how we treat them and things of that nature. So genomics is really cutting edge, even though it's been around for a little bit. There's still a lot of value in it. There's still a lot of new late breaking things that are coming about. And so the whole research trajectory of genomics has actually helped treat some of these disorders, and actually, in some instances, replacing the defected gene, which we're not here for an ethics discussion, but that could turn into a big ethical dilemma rather easily. And then the last comment, or the last term here, is heritability, and that's the risk for developing a disorder that may be transmitted to someone's children in a recognizable pattern. So in other words, we can look through generations. I can't remember if I included it on the slide, but a good general rule of thumb to do a thorough past history would go through 3 generations. And so when we can do that recognizable pattern, we can sort of predict what the hereditary and what the inherited traits are going to look like further along. For our very foundation of everything, we're looking at genes or genetics, not the genes that you put on your backside, but the genes that are found in our DNA strand. So all of this genetic material. The human genome, again, the entire DNA sequence, is about 20 to 25,000 individual genes. So that's what we're so complicated, okay? Humans are a complicated organism. If you haven't figured that out in anatomy and physiology, you certainly should be learning that in nursing. So we are composed of many, many thousands of individual genes, and then those all come together to form a very cohesive chromosome, which this particular chromosome is an X chromosome. A little bit about chromosomes. So we talked about the genes making up from the DNA strands. And then here we have this chromosome right here in the heart of the cell doing its little work, putting its work in. So these are highly condensed double-stranded DNA. And then we'll move to the center of a cell that is on the, I'm not sure what just happened there. I'm so sorry. Current slide. So they form and they move into the cell that's about to divide. So the cell is about to do its thing. The chromosomes enter into that cell, and then the cell will divide. Humans have 46 chromosomes that are divided further down into 23 pairs. And I'm talking about normal human genetics here. So then we have our sex chromosomes. These are genes for sexual differentiation of the human. A normal genetic male will have an XY chromosome, whereas a normal female will have a double X or an XX chromosome. Let's talk a little bit about patterns of inheritance, because this is kind of where it gets a little bit confusing. And so I've introduced some visuals for you guys. Again, the beauty of having these recorded videos, if you will, is the ability to kind of stop, take some notes, even screenshot. You get the slide deck. So there's a lot of benefits to these. But let's talk about autosomal dominant. Autosomal dominant. This is the affected individual has just one copy of a mutant gene and the other gene is normal. Okay, so one mutant, one normal gene. The reason why it's dominant is because that mutated gene is so powerful that we only need one copy of it for the disease to rear its little head up, to give us symptoms, to show that there's a disorder present. There is a 50-50 chance of passing it on to your offspring or children. Okay, so an autosomal dominant gene, dominant disorder, there's a 50-50 chance of passing it on to the offspring. We have this term called penetrance, and that means the mutated gene will come up with the symptoms of the condition. Now, not everybody will display symptoms of the disorder, but that makes them a carrier. Then the last term here we have is expressivity, and that's the expression of a gene of people with a certain phenotype. So let's take a look at what an autosomal dominant genetic link or hereditary link looks like. So we have the male over here, or the father, who has a normal gene and an abnormal gene. So this is the mutated gene that we talked about. We have an unaffected mother who has two normal genes. So what happens is, here is our 50-50 shot, guys. So the affected father passes along the abnormal gene. The mother passes along her normal gene, but because it's an autosomal dominant disorder, this one mutated gene is enough to have a child that's affected. Okay, child number 2 got the normal gene and a normal gene from mom and dad. Second unaffected child also got a normal gene from dad and a normal gene from mom. And then the fourth child got a normal gene from mom and an abnormal gene from dad. Okay, so again, they only need one abnormal genetic material, one abnormal gene, in order to produce the disorder. So 50-50 shot. The next pattern of inheritance is autosomal recessive. This is where it requires two mutated genes. So there has to be two defective genes that get inherited, one from each parent, in order to see the disorder in the offspring or children. Now, these types of disorders will affect males and females equally. It will typically skip generations, and I'll show you why here in just a minute. And autosomal recessive, there is approximately a 25% chance for two parents that are carriers to produce an affected offspring. So let's take a look at what autosomal recessive looks like. So here we have two unaffected parents. They're both considered carriers. The disorder does not show up in them because, remember, recessive requires two abnormal genes. Okay, that's the difference between dominant and recessive. Dominant, you only need one affected gene to show a symptom of a disorder, whereas autosomal recessive requires two defunct genes. So here's what happens. We have a little boy here who got normal gene from dad, normal gene from mom. We have a daughter here who received an abnormal gene from dad and a normal gene from mom, or vice versa. We have a child here who, again, either had, well, according to this picture, the dad gave the abnormal gene, the mother gave the normal gene, and then we have the one, here's the 1 in 4, or the 25% chance, who received an abnormal gene from mom, an abnormal gene from dad, and boom, we have an affected child. Now, what happens to the two middle children here? they are not affected by the disorder, but they then become a carrier. Okay, this is how it becomes or evolves into skipping a generation, because this particular child here could find a mate that is not affected, not a carrier of whatever genetic disorder. And so there's only one gene that gets passed along to his or her children. Okay. If they happen to mate with someone else who is an unaffected carrier, then again, the odds go back to 25% of them passing along that disorder to their children. But this is where it can most likely skip a generation, because again, this particular, it appears to be a female. This daughter has to find a male mate that is also a carrier in order for the disease to continue in that particular generation. We also have something called sex-linked recessive, also known as X-linked recessive. These affected individuals are mostly males because males only have that one X. Remember, they have an X and a Y chromosome. So if these disorders are X-linked, it can only affect the X chromosome, so it's more likely to show up in the male because they only have one X. Whereas females, we have two X's. And so if it's recessive, remember, we have to have two mutated genes. So it becomes a little more rare in females, although females are typically carriers and they are typically normal. All affected males will have the symptoms, and again, that's because they only have one X. And so if that X is damaged or mutated, then they will have the symptoms. Males typically are not carriers. They can only have an active disease, but technically they can pass it along as well. So let's take a look at that and see what it looks like. So we have an unaffected father and we have a mother who is a carrier. We now have a 25% chance of affecting the son because the mutated X gets passed along to him, and then dad, who already has a mutated X, gets passed along to him. You do have a chance of having a completely unaffected son. That means he has the normal Y from the dad and a normal X from the mom. The carrier daughter will receive the abnormal X from dad and the normal X from mom. Again, we talked about the affected son who would receive the abnormal X from mom and a normal Y from dad. And then the daughter here would receive two normal X or non-mutated X chromosomes. The other potential opportunity we have here to pass along would be the affected father. And typically, they can only pass this along and make an unaffected son or carrier daughter. So this is how this works. For this particular child here, you got the normal Y from dad, normal X from mom. Daughter here, the abnormal X from dad, normal X from mom. This affected son, just like the first one, the normal Y from dad, the abnormal or the normal X from mom. And then the carrier daughter would receive an abnormal X from dad and a normal X from mom. Now, the reason why the daughters are the carriers is because dad is the only one that can carry that X that is abnormal. Mom will have two normals. Okay, these children are 50-50 mom and dad. You can't get two X's from mom. You have to get an X from dad and an X from mom. Hopefully that makes a little sense. I know it gets a little confusing when we talk about affected and unaffected and mom and dad and who's got symptoms. So it can get a little crazy. So that's one of the reasons why I put the visuals in there, so you guys, again, can screenshot it, you can save it, you can print it, you can write it down, you can go back for reference of this. A couple more other kinds of patterns of inheritance, but you don't really see a whole lot talked about this. Primarily the conversations are around those autosomal and recessive and dominant and X-linked. But complex inheritance means that there's a combination of genetic changes in addition to environmental exposures that then cause a mutated gene. Okay, so it's not just a simple, I received a mutated gene from mom or dad. This is clearly a combination of multiple genetic changes as well as environmental exposures. And then we can have differences in more than one gene. So it can be multiple genes that get affected. And then we have this conversation about our topic about familial clustering. And what that means is a particular family actually has an excess or more than we anticipate expression of a genetic disease compared to the general population. So for instance, if we go back to those 50-50 of the autosomal dominant genetics, all of a sudden we have all 4 children that are positive. Okay, and so that is called familial clustering, which means that family is having more incidence of that genetic disorder than the general population, or what the general patterns of genetics says that they would. All right, so let's talk a little bit about genetic testing here. I don't want to go too much in detail because this is not my area of expertise, but I do know some basics here. Typically, it is divided into 2 categories, and it's a very broad category, and they all require consent. Okay, hint, hint, the NCLEX loves to do this. They love to set you up for this lovely procedure, making you think that you've got all this good interventions that you need to do, when the answer boils down to, I got to make sure there's a consent, because most genetic testing is invasive, which means that it can potentially cause harm to someone. So whenever that happens, we have to list out the risk and benefits, and the provider that is performing the genetic testing has to obtain consent. So very important, critical concept that a lot of people miss. You have to have that consent done. And so we have diagnostic screening or testing, and then we have screening. And diagnostic is used to rule out a specific genetic or chromosomal condition. So in other words, I take my child to the doctor because they're kind of short, they're not really growing appropriately. There may be some other things. There may be an easy bleeder, particularly here in a minute, because we're going to talk about hemophilia. So I would take them in, and then I would get testing for them to determine if there's a chromosomal abnormality. Whereas screening typically happens in the prenatal, so in utero, or in the newborn stage. Very early on, we have early recognition. Therefore, we can begin treating almost immediately. We identify who's a carrier within the family just by taking chromosomal samples. And so some of that may be amniotic fluid. There is some testing they can do on amniotic fluid. Of course, there is risk involved with genetic testing because, again, this goes back to needing consent. On the other end of that is genetic counseling, and this really comes after genetic testing, or sometimes it can come before, but part of this is how these genetic conditions can affect the patient and their future family, so further down the line. So once this genetic testing is done, we bring them in for genetic counseling, which again tells me my future risk. So if I actually go in prenatally, or maybe even before prenatally, so my husband and I decide to go get genetic testing to see who's a carrier. We get our results back. Then we move into the phase of genetic counseling, and it will tell us if we had positive or negative genetic results, genetic testing results. And then that's when we sit down and have that conversation. It's either a 50-50 chance, or it's a 25% chance, or whatever the odds are of producing an offspring or a child with the disorder. Genetic counseling also helps determine options to make health decisions. Again, if we go back to the prenatal testing of the amniotic fluid, if it comes out positive that my child will more than likely, they never give you 100% odds, but my child will more than likely have Down syndrome or Tay-Sachs disease or any of these other genetic disorders, we then sit down and we have the conversation. Do we continue with the pregnancy, or do we terminate the pregnancy? What kind of decisions do you want to make going forward, knowing this information about your child? The other part of genetic counseling is constructing the family history, or what we call a pedigree chart. This is typically completed by the nurse. And again, it should include 3 generations so we can see a pattern of genetic disorders in the family. So, of course, with any sort of testing or procedures that we do, there is this weighing of risk versus benefits. So some of the benefits of genetic testing is it would confirm a diagnosis, as well as identify at risk or the likelihood or the chance of developing certain genetic disorders. Now, the risk that go along with this is genetic testing results do not change. So in other words, I can't change the outcome. If you go to the doctor and you find out you have an infection, you can take an antibiotic, you clear up the infection, you move on with your life. Genetic testing does not change. When you're at risk for passing along a mutated gene to your offspring, that risk does not change. It is always there. There's also psychological and social risk, because if I tell a family that they're positive, they have to go through the process of, do we ever want to have kids? Does this change if we want to have kids? Do we want to put kids at risk? This is a potential. It's not 100%, but what happens if they do? There's a lot of what ifs that can interrupt normal processes. I know that the traditional family is changing. There's a lot of non-traditional couples out there, and that's fine. But for a traditional couple who thinks they're supposed to marry the opposite sex and they're supposed to have children and they're supposed to have the white picket fence and the cars in the yard and etc., like, the stereotypical American dream, if they all of a sudden get hit with, we got a 50% chance of creating a child with a disorder, does that interrupt their flow? Do they start thinking about things? I've actually had some families divorce over it because that's not the path that they wanted to take. And so there's a lot of social and psychological implications that go along with genetic testing that falls into the third bullet point, which is family disruption. I mean, you have some women that can't take it, or even men for that matter, and they can't stomach the thought of passing on a disorder to a child knowingly, like you go into it knowing it. And so there's that conversation that you have to have. Do we want to risk it, or do we say no, or do we want another partner? I mean, that can really disrupt a lot of families. Some tests have limited value for predicting future risk. Again, they don't give you 100%. It's a 25% odds or a 50% odds or 75 or whatever it comes out to be. And so there's still that chance. But you got to think about it. You got to weigh the risk and benefits. Is it worth continuing with the pregnancy? But I know that there's a chance. And then testing can identify a greater risk for a future serious health. So again, on the backside of that, it may save somebody's life. It may prevent you from reproducing and thus having a child that gets a genetic disorder that may or may not be treatable. So lots of things to consider when you go through with genetic testing. So, of course, we're in nursing school, so we need to learn the role of the nurse in genetic counseling. Genetic counseling is a process, okay? There's time in between when the blood gets processed and when it gets sent off. That time is much shorter than it used to be, but there is still time to process things. And it's also a process in the sense that you have to counsel them before, there's counseling during, and then there's psychological and social implications once the results come back. And so as the nurse, we learn very quickly on, or at least you should have in your studies, is that we advocate and we provide patient-centered care. At the end of the day, it doesn't matter what I would do in my situation. It's how we can support that patient in whatever decision they have to make. Of course, the nurse is always great at collaboration. We look at it as an interprofessional team. We have the provider, we have the social worker, we have us. We have different wheels that turn the whole machine. We are very good at observing ethics. We have to be very ethical in the decisions. We have to be very non-judgmental, which is not a bullet point up here, but one that I want to bring up is that we frequently have to check our judgments at the door. Just because a particular family chooses one way does not mean that's the right and only way. We maintain privacy and confidentiality. As you can imagine, these genetic disorders or being a carrier of a genetic disorder that comes with a high confidentiality need. Patients want to know that you're not all over the news blaring that they have a genetic or they're carriers for genetic disorder. So you have to be very careful with privacy and confidentiality. We make sure that they get clear and accurate information. Okay, we are all about communication and making sure the patient understands maybe what the provider just went over. You guys have all been in a patient room and you've heard a doctor talking way above the patient's head, and then we turn around and retranslate that information for the families. No different in genetic testing. And again, here's this concept. I know I've said it a couple times, but it is really important that we make sure there is a consent for genetic testing. All right, so some examples of autosomal dominant disorders are Huntington's disease, neurofibromatosis type 1 and 2. We have Marfan syndrome, tuberous sclerosis, and von Willebrand's disease, which we'll talk about von Willebrand's because our focus is on bleeding. Some autosomal recessive would be cystic fibrosis, sickle cell disease, Tay-Sachs, spinal muscular dystrophy, Roberts syndrome, and then hemophilia, which again we'll talk about here in just a minute. It is recessive, but it's specifically X-linked recessive. So there's the hemophilia, Duchenne's muscular dystrophy, and then Turner syndrome. And I have an asterisk beside Turner syndrome because most of our X-linked recessive disorders are males who are affected and show evidence of the disorder. But there is something called Turner syndrome, which actually expresses itself in females. This is a female genetic disorder where she receives a normal or an abnormal from the carrier mother, and then the mutated gene from the father who presents himself with having the disorder, because remember, he only has one X gene. And so the female actually gets a abnormal mutated gene from the father and an abnormal mutated gene from the carrier mother to produce Turner syndrome. Turner syndrome is not like common. It doesn't happen very often, but it does happen in females. They have a short stature. They don't tend to grow as big as normal, as a female normally would. Now, sometimes it's just short genetics, but sometimes it can be Turner syndrome. All right, so let's move on to hemophilia. Hemophilia is actually a group of bleeding disorders that come from a deficiency of certain coagulation proteins, also known as factors. And so you have two types of hemophilia. You have hemophilia A, which is the most common, which is the one we're going to focus on. And hemophilia A is a deficiency in factor 8. Hemophilia B is a deficiency in factor 9, but it is also called Christmas disease. Classic hemophilia is about 80% of all cases of hemophilia and occurs 1 in 5,000 males, whereas hemophilia B is only about 15% of cases and occurs in 1 in 30,000. So what is hemophilia A? Hemophilia A is an X-linked recessive trait, which means males are more commonly affected. The females are carriers. So the females will pass on the defect to the males. Female offspring are rarely born with the disorder, but if they have the affected gene from their mother and are the offspring of a father with hemophilia A, there is a small chance that females will have hemophilia, but the majority of them are males. Now, the degree of the bleeding will depend on the amount of that clotting factor that is missing or the severity of an injury. So if I slice an artery and I'm lacking a fair amount of my clotting factor, then I'm probably going to bleed quite heavily. Versus if I have a paper cut on my finger, while I may bleed more than usual, the chance of me hemorrhaging out may not be that high. Approximately 1/3 of all hemophilia patients have a known family history, and the disease in this 1/3 or 2/3 that don't have a family history, it's actually caused by a new mutation that hasn't been identified. Okay, on hemophilia, there are sometimes symptoms don't occur until 6 months of age, and the reason why that is because at 6 months, the baby becomes a little more mobile, starts to crawl, starts to scoot, a little bit older, around the 12. Well, every baby develops a little bit differently, but anywhere from 11 months to 16 months, they begin to walk. So they begin to fall, right? Toddlers, older infants and toddlers tend to fall a lot. They're clumsy, they trip, they run into things. And so the parent goes, you sure are bleeding more than normal. So typically symptoms you won't even see until they're about 6 months old. Again, the bleeding can be mild to severe depending on where the cut is and how much clotting factor is missing. We have this term called hemoarthrosis, and that just means that there's bleeding into the joint spaces like knees and ankles and elbows and shoulders, particularly after a fall. And we'll talk about this in just a minute, how we can kind of manage this hemoarthrosis. We have ecchymosis, which is also called bleeding, epistaxis, which is bleeding of the gum, or nosebleed, sorry. So we have bruising and nosebleeds, and then bleeding after procedures like a minor trauma or tooth extraction, some surgeries. One of the things that can happen at an area of injury is we could have subcutaneous or intramuscular hemorrhages, a lot of times often called a goose egg because it pops up really large, but you can see the bruising underneath the skin, but it may not be openly bleeding. And then also we run the risk of bleeding into the neck, chest, and mouth, which can compromise our airway. So typically hemophilia is diagnosed either through amniocentesis, which would be before birth, or genetic testing, which would be after birth. Diagnosis is based on, again, a thorough health history, a family pedigree. There are specific labs that we can draw, and then physical exam always works. So in our labs, what we're going to find is when we draw the blood of a hemophilic patient, we're going to have low levels of factor 8 or 9. Remember, that's either A or B. And then the key lab would be an elevated or prolonged PTT. Remember, PTT is a partial thromboplastin time, which is how long it takes for your blood to clot. And so, of course, now that you understand what a prolonged PTT is, that makes sense. The hemophilia bleeds longer than the normal person would. What you will find in their lab work is the platelet counts are normal, the PT level is normal, and even the fibrinogen level are normal. The only thing that becomes abnormal in hemophilia patients, again, this is another one of those things that NCLEX likes to test you on, is that prolonged PTT level. Now, way back in the day, we typically had about a 5-year lifespan on these patients because, sadly enough, they ended up bleeding out. But because of the genomics and the research that we've done on this disorder, they now live almost normal lives. We do have something called a gene therapy, which means we would actually infuse the carrier organism into the patient. These organisms actually will work on these target cells, and then that in turn manufactures deficient clotting factors. All right, so again, that second bullet is what I just went over. We can actually do clotting factor replacement therapy. We've actually been able, science, when I say we, I don't mean like me, I wish I had come up with this, but science has come up with a way to make a clotting factor concentrate. And so we can infuse that, which promotes the body to do those to produce more of those clotting factors. Another common response is DDAVP, also known as desmopressin. And this is a synthetic form of vasopressin, which is normally found in the body, but it is given IV, and it will actually promote clotting factors to start making on their own. So what happens is it will increase the plasma factor 8, and it can be prescribed to treat mild hemophilia, but it causes the body at about 2 to 4 times its normal rate to increase this clotting factor. Another choice would be a transfusion of packed red blood cells. That's always a good choice for treatment of the hemophilic patient. Again, depending on how much blood loss they've had. So big, huge things for nursing interventions. This is all about the bleeding, guys. Preventing bleeding, controlling bleeding. So close supervision, make sure they don't fall, make sure they're in a safe environment. The dental procedures have to be very controlled. Male patients should only shave with an electric razor. If there is superficial bleeding, we would apply pressure for about 15 minutes, and we encourage ice in order to promote vasoconstriction. If significant bleeding occurs, again, we would either transfuse with red blood cells, or we would do that factor replacement therapy that we talked about already. Some kind of other things that I didn't include on this, but in hindsight, I really want to add is monitoring neurological status, because if they fall in and hit their head, they could have a brain bleed and we wouldn't know it. Also, urine for hematuria, blood in the urine. We have to monitor for that. Another good idea is for children to wear protective devices such as helmets, knees and elbow pads, especially if they're going to be bicycling, skating, skateboarding, things of that nature. So I promised you we would come back to hemarthrosis, which is bleeding inside of the joint. So essentially, if the child falls and bumps their knee, and we know they have hemophilia, you're probably going to see swelling and bruising to that area fairly quickly. So it's very important that we elevate, we immobilize the joint, we add ice, we give analgesics, but not aspirin or NSAIDs, because we don't want to increase bleeding. So Tylenol is always a good option. We can do some range of motion once the bleeding stops, because we want to get that joint space moving again. If it becomes very serious, we might encourage physical therapy. And then, of course, we want to minimize weight, because obesity and people who are overweight that have hemophilia, we put more stress on our joints, which can worsen the bleeding episodes. All right, so we will move on to von Willebrand's disease. Von Willebrand's disease is a hereditary bleeding disorder. It's characterized by a deficiency or a defect in a specific protein. This is actually factor 8, and the protein is called von Willebrand's protein, thus the name von Willebrand disease. Basically, what happens is it causes platelets to adhere to damaged tissue. And of course, it's an increased tendency to bleed, but mostly from mucous membrane. So the gums, the mouth, anywhere there's a mucous membrane, that's where the high likelihood of bleeding comes from in the von Willebrand's disease. It is autosomal dominant. It can occur in both males and females. And typically the abnormal gene is located on chromosome number 12. Again, because of our work in genomics, we have learned that that's where von Willebrand's is buried. So again, bleeding things are what we're looking for. So there's easy bruising, so the patient bruises rather easily. Again, that epistaxis, which is the nosebleed, the gingival bleeding, especially when brushing the teeth. There may be excessive bleeding with lacerations or with surgeries. And then, unfortunately, for genetically known females, we have menorrhagia, which is heavy periods or heavy menses, excessive menstrual bleeding. In order to diagnose von Willebrand's, of course, we can draw blood levels to see what the factor levels are. There are von Willebrand antigen levels. Typically, these patients have decreased platelet adhesion or agglutination, if you want to be fancy. So the platelets are going to be off. There are prolonged bleeding times. But the difference between hemophilia and von Willebrand's disease is that PTT in von Willebrand's can be normal or prolonged. Remember, in hemophilia, classic PTT is going to be long. In von Willebrand's, it may or may not be long. So medical treatment with von Willebrand's disease, we can infuse that von Willebrand protein concentrate because, again, science has afforded us to be able to extract those proteins. Again, the DDAVP or desmopressin, particularly before procedures, before menses, and to treat active bleeding episodes. So we can actually preventatively infuse DDAVP, especially if we know there's going to be a procedure scheduled or right before periods for those females that have severe von Willebrand's, because again, those mucous membranes tend to bleed a lot. Nursing interventions stay about the same. Again, we want to avoid NSAIDs and aspirin because that's going to increase bleeding time. It, again, further inhibits that platelet function, especially aspirin. We manage the bleeding episodes with infusions. Okay, it's all about safety. The lovely part about von Willebrand's disease is most children who have been diagnosed with von Willebrand's will have very normal life expectancies. There are just some very minor adjustments that we would have to do for these patients. Okay, and I think, yep, that's all I have for you guys. So I'm actually going to put some questions up in the group as we continue to move along with this. But this was just a little bonus episode that I wanted to put together for you guys, so you could learn a little bit more about genetic disorders, and then we would talk about the two specific ones, the two biggies, if you will, of hemophilia and von Willebrand's disease. So if you have any questions, just let me know. Otherwise, I'll talk to you later. Okay? Bye, guys.